Hello again. So we're going to start our talk today, part two of esophageal diseases. So mainly we're gonna. Oh, sorry, why it's not moving? Right. So we're going to talk today about esophageal perforation and esophageal cancer. So esophageal perforation, to start with, it's a rare condition, but it's fatal. And most of the time, the underlying cause is actually iatrogenic. It's more than a spontaneous perforation. The mortality really depends mainly on how early you operate on those patients. So if you operate and within 24 hours or so, then the mortality will be around 13%. Whereas this mortality will be much higher if you operate after 24 hours. That, of course, depends on the patient age, his general condition, the location of perforation, and whether there is an underlying or pre-existing disease in the esophagus. So, as we said earlier, that mostly are caused by instrument or iatrogenic, and out of those instruments, of course, endoscopy, because it is widely used worldwide, and endoscopy per se may cause perforation in the neck or cervical esophagus in about 35%. And of course, if you add a procedure during the endoscopy, then each procedure has a risk of perforation. The most common site for perforation is actually where the natural narrowings inside the esophagus, within the esophagus. Remember, guys, from the previous lecture that we said there are three narrowings in the esophagus, and those are at the level of the upper esophageal sphincter, around C6. And at the level of aortic arch, where it crosses the esophagus, or the left main bronchus, and at the level of the lower esophageal sphincter. We'll talk about a little bit more the cervical perforation. Cervical perforation mostly caused by iatrogenic or by endoscopy. The causes that may increase the risk for perforation is when you have an inadequate sedation or anesthesia, when you have the patient is fighting with the scope or with the endoscopist, and or if you have the endoscopist is not really experienced in using endoscopy and manipulating the esophagus, or not following the rules like following the lumen of the esophagus. So once you have the perforation at this point, the problem is that the leakage of esophageal content and the saliva will cause some sort of infections in the neck and the deep spaces of the neck. Even worse, if it is neglected or it is delayed, this infection or the leakage actually goes into mediastinum, causing more fatal problems, which is descending mediastinitis. 80% of those patients come with pain in the neck, and of course dysphagia with odynophagia. On examination, they will have some tenderness in the neck, and because of the presence of sub-Q emphysema, they will have some sort of crepitation. If the patient present late in the course, they will have, of course, signs of sepsis and infection. Of course, they're going to be fever and leukocytosis. On X-ray, you will appreciate the loss of lordosis because the patient cannot move the neck properly, and you will also appreciate the presence of sub-Q emphysema, sometimes an anterior displacement of the esophagus and the trachea. While in the chest X-ray, with the chest X-ray, you may find the sub-Q emphysema, and most importantly, you will see a pneumomediastinum. If the presentation is a little bit delayed, there will be a pleural fluid, which is usually found after 24 hours. Now, gastrographin or esophagogram is very important. I think this is the most sensitive test to diagnose the perforation. The problem with gastrographin alone, which is the water-soluble dye, you can basically miss 20% of the cases. So that's why we have to insist and to tell the radiologist that if you have gastrographin negative, you have to push for a thin barium, because barium is a little bit more thicker and more sensitive in picking up the perforation. Endoscopy in any perforation is paramount, and endoscopy here is not contraindicated as most of the people think. But there are conditions. So if I want to do endoscopy, endoscopy should be done in the operating room with the intent that you're going to operate while doing endoscopy or right after doing the endoscopy. All right. So the endoscopy will tell us basically if there's perforation, where is it exactly, how big the perforation, but it's better be done in the operating room. So of course, once you suspect the perforation in the neck, those patients should be admitted right away. They should be kept MPO. Again, nasogastric tube in this situation is not contraindicated. Nasogastric tube should be inserted under guidance, either endoscopy or through through radiology. And of course, you should start those patients on broad spectrum antibiotics. The paramount or the mainstay of the treatment of those patients is actually you have to operate on them right away as soon as possible. Whatever is the condition of the patient, this patient should be in the operating room as soon as possible. So our approach is usually in the neck, usually from on the left side of the neck, and the reason we do the left side because again we know the course of the recurrent laryngeal nerve, which is usually in the groove between the esophagus and the trachea. So the chance of injury is going to be very, very low in this situation. So while you're opening the neck anterior to sternocleidomastoid, dissecting down, you will face the middle thyroid vein. You have to divide it, and then you will face the omohyoid. Again, you have to divide it. I usually divide it distally from toward the distally from the origin. The reason is because I save the omohyoid for the repair to buttress it, basically buttress my repair. Anyway, so divided laterally, and then you have to dissect down until you reach to the vertebrae. Once you reach to the vertebrae, basically the esophagus will be right above your finger. Dissect or encircle the esophagus and apply pinrods around it, retract it, mobilize the cervical esophagus. If you are lucky enough, basically you will identify the lesion or you will identify the injury. One thing you have to remember that if you see the injury, just bear in your mind that the injury on the mucosa is actually longer than the injury on the muscle. So you have to open up the muscle distally and proximally until you reach the edge of the beginning and the end of a mucosal injury. Then only then you can close the layers. You close the injury in 2 layers with interrupted absorbable suture. I usually use 3 or 4 Vicom. After closing your injury or the perforation, I always buttress it with muscle. Either I use the omohyoid or partial or part of the sternocleidomastoid, and then I attack it basically on my repair. Once you finish, make sure that all the deep spaces in the neck are drained properly and cleaned and irrigated. And just before closing up the neck, I bring basically 3 drains. The a corrugated drain, I leave a drain in the mediastinum and drain just beside my repair. And the last drain, actually, I leave it for irrigation. And I do irrigation like, post-operatively regularly. What about in case you open up the neck and you did not see the perforation? You don't have to worry. You don't have to basically worry about looking for it. So if you did not see it, then the things you have to do is make sure that you drained and cleaned all the deep spaces in the neck, and leave a lot of drains, sticking out the neck. That's going to help you. That's going to be your safety valve, basically, to prevent future sepsis and medicinitis. So post-operatively, I keep the patient fasting, and I keep nasogastric in tube in place, and I leave them on IV antibiotics for almost a week, and then after a week, I do a gastrografin. If they pass gastrografin, barium followed by barium, then I start feeding them gradually. This is regarding cervical perforation. What about the perforation that occurs in the chest or abdominal perforation? So the causes are going to be more or less the same. It's either mostly due to instrument or iatrogenic, but 10 to 15% of the cases are iatrospontaneous. Probably all of us know it or know the syndrome is called Boerhaave syndrome, and we'll talk about it shortly. Other causes, of course, caustic injuries, carcinomas, infections sometimes. Whatever is the cause, we'll talk about how do we manage probably most of them. The risk factors that in endoscopy that may increase the risk of perforation is again more or less the same as cervical, as if you have poor sedation, or the endoscopist is not following basically the lumen, or the endoscopist basically dilating the strictures inappropriately, or trying to dilate not dilatable strictures. Again, if biopsies are taken blindly, it's a risk factor for perforation. So whatever you do, try to be safe as much as possible when you do an endoscopy, if you are doing endoscopies. Perforation in the abdomen and the chest present with substernal and epigastric pain that may radiate to the back or left shoulder. Sub-Q emphysema are evident in 20% of the cases. And of course, the pneumomediastinum is also a sign on chest x-ray. If the perforation in the chest or lower esophagus basically, if the perforation is delayed, the mediastinal pleura may open up, and the patient will present with the pleural effusion. You need to work up those patients quickly. Always, you have to have a high grade of suspicion. Patient comes to you with history of endoscopy just a few hours ago or last day, for example, and then complaining of chest pain or epigastric pain, or patient feeling sick or dysphagia. Then you have to investigate those patients as esophageal perforation unless it's proven otherwise. So you obtain your chest X-ray. Again, chest X-ray may show some pneumomediastinum or hydro or pleural effusion or pneumothorax, air and the diaphragm here, and gastrografin followed by thin barium. You may have a free leak into the chest. CT scan probably is a paramount in diagnosis and working up those perforation patients. It gives us a lot of information regarding the esophagus, probably whether, what I mean, it will give us crude inflammation and indication about the site of perforation. But most of the time, what we feel as a surgeon, and when we ask the radiologist to do a gastrography followed by thin barium, we find a lot of resistance. They tend to like to do a CT scan more than barium swallows. As a surgeon or as a caregiver, I think you should insist on gastrography, because a CT scan is a very nice tool to diagnose the perforation. But the problem that CT scan is not as accurate as gastrography in locating the perforation, whether it's right side, left side, whether it's a little bit high, a little bit low. So I think you should obtain, nowadays, you should obtain both gastrography and CT scan. You can consider CT scan as complementary. The second, Boerhaave syndrome is very well known esophageal perforation that occur in the lower esophagus. The first report was by Boerhaave, Professor Boerhaave, in the 1700s, where he was called to assess a general or admiral of a native fleet, which had a problem with a severe epigastric pain after heavy meal and vomiting. Anyways, the pathophysiology of Boerhaave is that when you have a sudden increase in the esophagus of pressure against a closed upper esophageal sphincter, and usually it is due to a forceful vomiting. Patient, for example, a drunk patient or heavily sedated patient with repeated vomiting, they basically are going to have an sudden increase in intraesophageal pressure against a closed upper esophageal sphincter. On the other hand, we have a Mallory-Weiss syndrome or Mallory-Weiss injury. The Mallory-Weiss actually is not a perforation. What you have is a mucosal tear, and those patients, when they present with hematemesis most of the time after forceful retching and vomiting. And usually they don't have the pain that they have it in Boerhaave syndrome. So usually Boerhaave tear is longitudinal with well-defined edges. The length ranges between 0.5 centimeter to 20 centimeter, and most of them actually between 2 to 6 centimeter above the diaphragm. Why this location in left posterolateral? The theory is that the tear or the perforation occurs where the weakest point in the esophageal wall, which is the entrance of any vessels, of the vessel. So 80% of Boerhaave syndrome are men, and usually they are in their 40s or to 60s of age. The pain they complain usually is tearing in nature, epigastric or substernal, depending on the location. The pain usually radiates to the back or to the left shoulder, and the pain is aggravated on swallowing. If the perforation or presentation is delayed, then this condition is progressed to mediastinitis, and in severe situation, they will present with shock. When you have dysphagia and pain, you have to think of the differential diagnosis. This kind of pain is also seen in, for example, dissecting aorta or perforated septic ulcer or pancreatitis. Just bear in mind those differential diagnoses, but always have a high grade of suspicion toward esophageal perforation. So the investigation for Boerhaave usually starts with history and physical examination. I usually check the X-rays or do the X-rays before anything else. The X-rays finding, as we discussed earlier, usually there is a subcu emphysema or air under diaphragm. You might evaluate or not see actually hydropneumothorax. And if you see like a pleural effusion and you would drain it, then you might drain actually food content or food particles from the chest. Again, gastrographin, esophagogram is very important here and the more sensitive test to evaluate a perforation. Usually, it gives us the location of perforation accurately and also map the esophagus, especially if we cannot reach or if we can't do endoscopy. CT scan is also important to give us further information about the disease and underlying pathology. Endoscopy here in BORHAF is not contraindicated, and usually it's indicated if we cannot obtain a barium swallow. Most of the time, what I do is actually endoscopy should be done in the operating room with the plan to operate at the same time. So the best treatment for BORHAF syndrome is never delay it. Admit the patient, resuscitate, hydrate, start them on IV antibiotics, broad spectrum with PPI. Nasogastric tube should be inserted carefully, guided insertion, and try to push them to the operating room within the first 24 hours. Why the 24 hours? Because if you delay the treatment, there will be a higher mortality, and the risk for a post-operative leak is definitely higher than the first 12 to 24 hours. And to ensure a successful management of BORHAF, make sure you do a proper debridement and drainage of a pleura with decortication. You have to have a really good leak control, and we're going to talk about that shortly. A proper lung re-expansion after decortication is very important for ventilation or ventilatory support and for the healing of the perforation, because we are expecting that the lung will adhere to the perforation site. It's very important to ensure a good nutrition and ventilatory support with the broad spectrum antibiotics. It's also important if you have this kind of patient or patient with perforation, make sure that you follow those patients closely and don't miss a residual septic foci after the procedure. So we have two methods for treating the severe perforation, either operatively or non-operatively. Operative management, we have many types, so we have options depending on the location, depending on the patient condition, and depending on the esophageal status before your surgery. So the operative management, we can close and buttress the patch. We can exclude and divert those patients, or drain and control the fistula by putting a T-tube or Malcut drain. Or last but not least is you proceed with esophagectomy. On the other hand, the non-operative techniques for management of BORHAF perforation, it's growing, and now more and more we are using more endoscopic control of a leak than the operative control. It doesn't really replace it. You have to know both of them, and you have to know that both options are available in your hospital. So the non-operative technique, we can apply endoscopic vacuum dressing. The vacuum dressing actually through is going to be inserted through the hole, and then basically you have to follow this patient and change the dressing every now and then. To be honest, I had never seen this before. I've read about it, and they have a very good results. Clips and stents are other options. In the clips, if the patient or if the perforation is fresh with a clean esophagus and a clean stomach, then you can apply clips to close the mucosal tear, especially if the perforation is less than 2 centimeters. Otherwise, you can insert option for you can insert the stent for your perforation, especially covered stent to cover the hole. The success rate is very high with low mortality. Usually keep the stent in place for 2 to 4 weeks, and then we remove it, and then we confirm with or by doing a barium swallow or gastrografin swallow. I guess we have to ask ourselves, when do I really use the non-operative management, and how should I use it? How we discussed that, but when I think if you have a stable patient, no evidence of sepsis, early presentation, that means less than 24 hours, and with minimal contamination basically, and or contained disruption. That what I mean is the leak is not free. Then only then you can observe those patients, keep them MPO, IV antibiotics, guided nasogastric tube, PPI, proton pump inhibitor to suppress the acid, and you have also to ensure somehow of feeding. You have to feed this patient either through parenteral or enteral. In other words, basically this is called Cameron's criteria. Cameron's criteria, guys, you have to remember that. Why? Because clinically you have to decide when to observe and when to operate, and it's important for your, I think it's important for your exam. So Cameron's criteria states on that the perforation is basically limited. That's a small perforation. The leak is contained. That means that it's not a free-flowing leak in the mediastinum or in the pleura, and it's important that the leak goes back into the lumen. So it doesn't really mean it leaks out but doesn't go back in lumen. It's important that it basically finds its way back to the lumen of the esophagus. Absolutely, there is no distal obstruction. If there's distal obstruction, then there will be no healing. Of course, the perforation should not be in the abdomen. It should be in the chest. And lastly, that the esophagus has no underlying salvageable, basically, no underlying malignancy, or there's no underlying end stage like stricture, for example. This Cameron's criteria is very useful and actually is very effective. Otherwise, we have to operate. Then the question comes to us is, what is my approach and how I can operate on those patients? Before that, I think you have to remember a few things, and those are important. If you want to operate on the esophagus, if you want to operate on the upper or the middle third, then your approach is going to be on the right side of the chest. You do right thoracotomy. If you want to operate on the lower esophagus, then your approach is going to be through the left thoracotomy around the 6th or 7th intercostal space. If you have a perforation or perforation with a pre-existing disease, then both perforation and the pre-existing disease should be addressed at the same time. For example, if there is a perforation and achalasia, then what I do is close your perforation in 2 layers, and opposite to the perforation, you do your myotomy and fundoplication. If you have a stricture, benign strictures with perforation, then before you repair your perforation, you do an intra-op dilatation of that stricture, and then close that perforation, buttress it, and then make sure that you do fundoplication to treat the underlying disease, which is reflux. In case of in case of cancer with perforation, then esophagectomy and reconstruction in later stage is very important at this point. So the steps or the operative steps in perforation, especially in the lower esophagus, is the approach is going to be on the left thoracotomy in the 7th intercostal space. While you're in, you have to prepare your muscle flap for buttress, which is intercostal muscle. Once you are in the thorax or thoracic cavity, make sure that you drain and remove the gunk in the chest, and make sure that also you decorticate the lung, allowing the lung to re-expand again. Once you've done that, so you have to identify or you have to operate on the esophagus. To reach the esophagus in the chest, you have to identify the inferior pulmonary ligament and mobilize it. Once the inferior pulmonary ligament is mobilized, the esophagus will be just beneath it. You will see it, and you will feel it, especially if you put nasogastric tube in the esophagus. Identify the esophagus, open up the mediastinal pleura all the way up to drain and to clean up the infection, and encircle the esophagus with a penrose and try to visualize or identify the injury. If you cannot or did not see the injury, then you can ask your colleagues anesthesiologists to inject air in the nasogastric tube, and or they inject milk sometimes, or food dye. So if you identify now the injury, remember that the mucosal injury usually longer than the muscular injury. So open up distally and proximally the muscle until you reach the edges of the mucosa. Then you start closing them with interrupted suture, absorbable after, of course, after cleaning up the edges. The closure should be in 2 layers, mucosal layer and muscular layer. And then, of course, I usually buttress it with intercostal muscle or other tissues for buttress. For example, we can use the diaphragm, omentum, stomach, pericardium, and so on, basically. Right. Before you close the chest, what you have to do is actually you put a lot of drains. I usually put a drain in the chest, just beside my repair. Put a drain in the mediastinum and an extra drain. There is no patient comes out the operating room after esophageal perforation without a G tube and J tube, gastric tube and the genostomy tube. The gastric tube is for decompression of the stomach and preventing the reflux of the stomach content into the or through your repair. You don't want to do that, basically, or your repair is gonna break down most of the time. And the genostomy tube is for feeding. Post-operatively, after this kind of procedure, what we do, we send the patient in the ICU ventilated for 24 to 38 hours, allowing us to resuscitate more the patient and correct whatever problems there, and allowing the lung to expand and adhere to the repair so that it may speed up the healing. Those patients are kept 5 to 7 days fasting, but we start the genostomy feeding tube in the first day. And of course, we continue antibiotics and proton pump inhibitors. During his hospitalization, or the hospitalization patient, always monitor those patients. If you suspect any leak, then you should ask for urgent gastrographin or barium swallow. So this is one type of repair, which is closure and buttress. The other type of repairs is, or of surgeries, are esophageal exclusion and diversion. Exclusion and diversion meaning that we exclude the esophagus by stapling off or ligating the GE junction. And we leave a T-tube or malacute drain through the hole, through the esophagus, to control the fistula, and then diversion is basically we divert the esophagus in the neck, bringing out a spit fistula or esophagestomy, usually on the left side below the clavicle, and of course we conclude our surgery with leaving gastric tube for drainage and decompression, and the genostomy tube for feeding. Right. And a few years back, we had few cases, 2 or 3 cases, that the patient's family refused to do an extensive surgery like esophagectomy for a delayed presentation septic patient. So we basically improvised this kind of surgery back then, and then I realized, it has been done in a few centers. So we asked the gastroenterologist to insert a stent in the esophagus to close the lumen or close the perforation, and followed by gastrographin on the same setting. In the same setting, if we ensure there is no leak, then we take the patient to the operating room, and with minimal invasive technique, VATS, then we decorticate and we debride the whole mediastinum and leave drains on those patients. The outcome is really good in this situation. Right. What about esophagectomy? Esophagectomy is reserved for those patients with underlying problem, meaning that the patient presented with perforation plus an underlying condition like cancer, for example, or stricture that is not dilatable, or the esophagus is completely basically damaged, then the primary repair of the esophagus is not warranted. So what we do here is we do total esophagectomy, and the reconstruction is not going to be in the same setting. The reconstruction is going to be probably 6 months or 12 months later. So what we do here, we do esophagectomy, debridement, cleaning of the thoracic cavity. We leave gastric tube and the genostomy tube, and then we bring a spit fistula on the left side just below the clavicle. The abdominal perforation, usually they carry an excellent prognosis, and the treatment is more or less straightforward. You close the perforation either primarily, or you just patch it basically with a Fundagrab or Omentum and buttress it. Leave G-tube and J-tube. The good thing about laparoscopic or laparotomy or open technique or this situation is actually you can drain the mediastinum through the abdomen, through the hiatus. With all this technique, the results of esophageal perforation depends on the cause or the location of the perforation and the timing of the perforation. What I mean is that the mortality is high in the chest, for example, in Boerhaave syndrome, whereas mortality is low if you have neck perforation, and the mortality is even worse if you operate more than more than 24 hours. The mortality may reach to 45 to 50%. That concludes my presentation about the esophageal perforation. The second half of this review is going to be about esophageal cancer. To start with, esophageal cancer is really bad disease. It carries a high mortality, is ranked 6th among all cancers. The treatment is available. The treatment may carry a cure, but the problem, even the treatment, is going to be lethal and affects the quality of life. Esophageal cancer affects more men than women, usually in 6 decades or 7 decades of life. We have two main types of esophageal cancer. It's either squamous cell carcinoma or adenocarcinoma. The squamous cell carcinoma may affect any part of the esophagus, but mostly the upper half. Adenocarcinoma, it affects mainly the lower half and the GE junction. Every year, we have probably 17,000 new cases, and the death is 16,000. It tells you how bad is the disease. The 5-year survival is about 19 to 20%. And recently, not recently, in the 1990s, we noticed a shift or change in the epidemiology. At the beginning, in the 1970s, mainly the tumor is squamous cell carcinoma that affects Black people, whereas especially, I'm talking about Western countries here, especially, but in 1990s and on, the cancer became adenocarcinoma more, and increasing in the parallel to increasing GERD and obesity. But worldwide, squamous cell carcinoma is still #1 cancer. In the Western countries, adenocarcinoma, but worldwide is squamous cell carcinoma. The pathophysiology of squamous cell carcinoma, usually squamous cell carcinoma associated with alcohol consumption and smoking. Alcohol and smoking, they act together synergistically. So alcohol prepares the environment for smoking carcinogens to work into the epithelium of the esophagus. Whereas in adenocarcinoma, as we discussed earlier, that GERD is the main risk factor for adenocarcinoma. GERD may progress to Barrett's and Barrett's to adenocarcinoma. And Barrett's, what happens actually, there will be a mutation, and genetic mutation in TP53 suppressor gene and alteration P16. Hence, eventually you're going to have a cell cycle is also altered. Adenocarcinoma, other risk factors or etiology is obesity, especially the central obese patient. What happens, the hypertrophied adipocyte in those people will have a low-grade continuous chronic inflammation and the release of cytokines. Those inflammation and irritation will lead to tumor growth and progression. Again, smoking may be a risk factor for both, but squamous carcinoma mainly smoking and ethanol together. Diet is another factor for squamous cell carcinoma, especially those rich in nitrosamine or aflatoxins, low in fruits and vegetables. Infection, it has been, human papilloma virus actually has been isolated from a lot of squamous cell carcinoma patients. Tylosis is one of the autosomal dominant conditions that is characterized by hyperkeratosis in the palms and sole of the feet. Those people, unfortunately, 90% of them, they will have squamous cell carcinoma by the age of 70. That's why it's always recommended for those patients to undergo surveillance by the age of 20. Other etiology or risk factors are caustic strictures, achalasia, hot drinks, and Plummer-Vinson syndrome when you have a severe web with iron deficiency anemia. On the other hand, we have GERD. We have adenocarcinoma. GERD is the main risk factor. GERD reflects to acid or bile. And the risk the risk of adenocarcinoma and Barrett is actually 30 to 60 times of normal people. And the risk of high-grade dysplasia in Barrett's esophagus to progress to adenocarcinoma is actually 7% annually. So that's why we have to pay attention to those people and start following them closely. In adenocarcinoma, another risk factor is obesity. In obesity, we have actually not only the inflammatory process that leads to adenocarcinoma, but actually there is a mechanical process. The mechanical process will eventually lead to GERD. So obesity is kind of a double warning thing, mechanical process and inflammatory process. Before we talk about the treatment or workup of those patients, I would like to mention something about prognosis of those patients. The prognosis of esophageal cancer is actually stage related. We all, as I said earlier, that the 5-year survival is about 19% to 20%. The prognosis is improved after surgery, especially those who receive chemo or radiotherapy or neoadjuvant therapy. Those are subgroups with complete response. The survival rate may double up to 48 to or 50%. The people or patients with stage 0 or stage 1, the 5-year survival is probably between 80 to 100%. But the more or the worse the stage, of course, the survival will be next to nothing, especially in stage 4. Sometimes we can predict the survival or prognosis preoperatively before the surgery or before pathology. PET scan can predict the survival or prognosis. For example, it was found that if there is an increase in uptake, SUV uptake on PET scan, there will be the prognosis is poor survival. The same thing, if the HER2 overexpression was found and gene amplification was found in that patient on the biopsy, then the survival is going to be poor. So imaging and HER2 overexpression can predict prognosis and can predict survival. So those patients with esophageal cancer, most of them, they present most commonly with dysphagia. It's usually progressive dysphagia, and half of the time they present with weight loss. But what I'm focusing on is actually those patients when they come with hoarseness of voice. That means that there is a recurrent laryngeal nerve invasion, which indicates that the disease is so bad and most probably it's not going to be curable. So you have to palliate those patients. Sometimes the patient, if there is a distal obstruction, they come with aspiration pneumonia and respiratory symptoms. The examination is not very revealing unless there is a metastasis in the abdomen and the liver, or there is a supraclavicular node enlargement. Then you can feel them. The differential diagnosis for those patients is actually differential diagnosis for dysphagia. Any patient with dysphagia, you should think of esophageal achalasia or stricture, or sometimes even benign tumors or a pathology in the stomach, for example, a gastric cancer. So we have to work up those patients properly. And endoscopy and biopsy is probably the cornerstone of the workup, in which we can diagnose, and sometimes we can actually deal with the tumor endoscopically. So the workup is going to be endoscopy and biopsy. In addition to this, CT scan, PET scan, AUS, barium swallow, bronchoscopy, those are all tools that we can use not only to diagnose, is actually to diagnose and to stage the same patient. So diagnosis and staging, they go parallel with each other. So a CT scan is very good to assess locally the tumor and the relationship to other structures like invading the aorta or invading the vertebrae or the trachea. So CT scan is very good also in M stage to exclude metastasis. PET scan, on the other hand, it's very good to assess the M stage metastasis and the lymph node status. As we mentioned earlier, that SUV uptake reflects the cancer behavior and the prognosis. The more the SUV, the worse the disease. EUS is paramount in the paramount tool in the workup of patients with esophageal disorders, or esophageal cancer. So it is the most sensitive tool to assess the depth and the lymph nodes. And the sensitivity is actually increased by needle biopsy, by adding needle biopsy to the ultrasound. The thing that EUS is very good to differentiate between T1 and T2 lesions versus T3 and T4, whereas unfortunately it's not very good to differentiate between T1, T1A versus T1B, or T1 versus T2. Other tools for diagnosis and staging, bronchoscopy. Bronchoscopy is not used on everyone. Bronchoscopy, Bronchoscopy is actually used if you have upper half esophageal cancer. Then you do bronchoscopy just to rule out any invasion to the airway. Barium swallow probably is not good for staging, but I think it's important to obtain it to map the tumors that are not actually accessible by endoscopy. And there are signs on barium swallow. Those signs are upper core stenosis, shouldering on barium swallow. Those are the shoulders, and pre-stenotic dilatation, and turbulence of a flow. Like if you witness the barium flow through the strictures, it's not going to be easily flowing. It's going to be basically there will be turbulence. Those are the signs of cancer in barium swallow. Once you finish your workup of those patients, once you finish the workup of the patient, we block them on TNM 8th edition staging. I'm not going to explain or talk about the TNM staging here, but I'm going to focus on a few points of it. I'm interested in a T stage and the relationship to the esophageal wall, and what is the clinical impact of those things. So TIS and T1A, T1B, those should be limited to esophageal mucosa or submucosa. So TIS or M1 is through the mucosa, but limited to laminar propria. T1A is subdivided into M2 and M3. That is through the laminar propria and through probably muscularis mucosa. Limited by muscularis mucosa, but not through it. T1B is in the submucosa, and according to the depth, they are subdivided into SM1, submucosal 1, submucosal 2, and submucosal 3. The clinical impact is actually we can predict the lymph nodes involvement. So the deeper the T, the more chance of, or the more risk of involving the paraesophageal lymph nodes. So if we have TIS like in M1, the risk of lymph node involvement is going to be 0. Whereas the deeper you go, the risk increases, and until reach, for example, the SM3, which is T1B, the chances or the risk of involving the lymph nodes is up to 45%. In addition, actually nowadays we use a procedure called endoscopic resection. I think I talked about it shortly on the other time. So endoscopic resection, in which what happens basically, they inject the lesion below the lesion, and then they snare it out. And this lesion get actually analyzed by the histology, and then we'll get the results. We'll get the depth of the lesion into the mucosa or submucosa, the differentiation, and whether there is a lymphovascular invasion or not. In fact, this kind of resection, the endoscopic resection, may be a tool for cure. That means that those patients with T1A and T1B, you might cure them if you did this alone without doing an extensive esophagectomy. So they may be a cure if the lesion is fully removed and the submucosa is not involved, or submucosa also removed. There is absence of lymphovascular invasion. The histology, if it is well differentiated with a clear margin, then actually those patients are cured just by the endoscopic resection. The Society of Thoracic Surgery, they have guidelines for working up and staging patients with possible esophageal cancer. So their guidelines or their recommendation is as follows: endoscopy should be endoscopy and biopsy is primary for diagnosis. Then that means we cannot basically get rid of it, and we cannot rule it out. The CT, PET scan are really good for staging, especially for local regional involvement. Even endoscopic ultrasound is excellent tool for to evaluate the depth of the tumor in the esophageal wall and assess the lymph nodes surrounding it. But if the CT scan or PET scan showed some sort of metastasis, then you don't have to do endoscopic ultrasound. It's going to be useless, basically. They included an endoscopic mucosal resection, and they consider it as a diagnostic and staging tool, especially if the nodule is small, less than 2 centimeters, or you can do EMR for dysplasia. They also recommended that in local regional disease or locally advanced disease, it is advisable to do a laparoscopic staging to make sure that there is no peritoneal metastasis or involvement. For you guys, what I'm basically trying to say is that despite the EMR and endoscopic technique, the gold standard treatment is esophagectomy for esophageal surgery. Esophagectomy is widely performed in the world, and the results are very good results, and the promising new techniques also now in the market, helping the patient and helping the good outcome. So the gold standard for esophageal cancer is esophagectomy. Okay. The NCCN, they have kind of different approach, or they have a guidelines, basically, not different approach, but the guidelines. And I think they are really good if you have the facility. So in the NCCN approach, they recommended that endoscopic therapy, either ablation or resection, like endoscopic mucosal or submucosal resection, are indicated for high-grade dysplasia or lesions that are T1A or T1B, and tumors less than 2 centimeters. And also they are recommending that esophagectomy is warranted and indicated in extensive high-grade dysplasia, or T1 that are not or cannot be controlled or adenocarcinoma that cannot be controlled by endoscopic resection. So they recommended that basically you can do any type of resection, esophageectomy, but the best conduit is going to be a gastric conduit. They also recommended that in squamous cell carcinoma and adenocarcinoma, if the lesion is T1B or they have any positive lymph node, then those patients should undergo a neoadjuvant chemoradiotherapy before surgery. But if you then, like, you know, after the neoadjuvant chemo-rad, you can basically operate on them. But also after surgery in squamous cell carcinoma, if you have an R0 resection, that means that you remove the whole thing without leaving anything, then you don't need really a post-operative chemotherapy. This is squamous cell carcinoma, but in adenocarcinoma, regardless of type of resection, whether it's R0, R1, or R2, it is advisable that those patients have to receive a post-operative chemotherapy. So what are the indications of surgery and contraindications for esophagectomy? The indications for esophagectomy is any patient that is candidate for surgery should undergo surgery in esophageal cancer. And also, which the thing that we are using now, still we are basically following this recommendation, is that if I have high-grade dysplasia that we cannot adequately remove by endoscopic resection, then we should proceed with esophagectomy in this situation. The contraindication of esophagectomy or tooth esophagectomy is when you have an N2 disease, lymph nodes involvement, or distal metastasis. Then you know, those patients should undergo induction chemoradiotherapy or neoadjuvant. Then you think of or you reevaluate for possible esophagectomy. Comorbidities are not absolute contraindication, but they are considered a relative contraindication. So esophagectomy is the procedure and gastric pull-up or reconstruction, and I think the esophagectomy is critical to the multidisciplinary team or multidisciplinary treatment. As I said earlier, that not every hospital or not every center they have the facility of endoscopic mucosal resection. Luckily, here in Kuwait we have it, and we've been cooperating with our colleagues in Al Jahra Hospital. They have the technique, and they're doing a pretty amazing job actually. For esophagectomy, whatever type you do, whatever type that you prefer. In fact, so far, all the trials and all the reports worldwide showed there is no survival difference between different surgeries. Probably the most important factor that's affecting your survival or patient survival is the stage of the tumor. All right, so the thing that is every patient should go for esophagectomy when they are diagnosed with quote-unquote esophageal cancer? The answer is not really, and I think those patients should be looked up like into their diseases closely, and you have to differentiate the type of the tumor, location of the tumor. So what happened is Seward came in and set his own classification. According to Seward's classification, then we can we do or we map our surgery. What I'm saying is that the location of the tumor is very important. The Seward classification, the type 1, is actually when you have the tumor proximal to the GE junction between between 1 and 5 centimeters. If you have C-word type 1, then your surgery is going to be esophagectomy. C-word type 2. C-word type 2 is the tumor is located in the GE junction, so it's called a true GE junction tumor. If you have the GE junction tumor, C-word 2, then your operation is going to be esophagectomy. Whereas C-word type 3, in which the tumor is located in the cardia, then that may extend to GE junction, then the proper surgery is going to be total gastrectomy, not esophagectomy. So it's important before you operate on those people, you have to classify and you have to identify which procedure by C-word classification. All right. So what are the types of esophagectomy we have? So we have two main approach, either transthoracic or transhiatal. The transthoracic is subdivided into two types of procedure. So we have Ivor-Lewis, which is a two-hole techniques, right thoracotomy and laparotomy or laparoscopy. And we have McEwen. McEwen is a three-hole techniques, in which there will be a right thoracotomy, laparotomy, and neck anastomosis. Whatever is the procedure, transthoracic, the step is going to be the following. Just like, you have to, if you are using Ivor-Lewis, then you start with the abdomen before the chest. If you are basically performing McEwen, then you start with the chest rather than the abdomen. Okay, I'm going to be clear a little bit more. So in Ivor-Lewis, what we do is we explore the peritoneum, make sure there is no peritoneal metastasis, and then we start mobilizing the stomach. When you mobilize the stomach, make sure that you preserve the right gastric and right gastroepiploic vessels. Those are the most important vessels for your conduit. Otherwise, if you injure this vessel, then your conduit is going to be useless, and you have to look for another conduit, like, for example, colon. After mobilizing the stomach, then you can start mobilizing the GE junction and enlarge the hiatus. And before you close the abdomen, either you do pylorectomy as a drainage procedure or not. It's up to you. But classically, we do a pyloromyotomy or a pylorectomy. And then before closure of the abdomen, we leave a feeding jejunostomy in place. Then we reposition the patient into left lateral. The approach is going to be on the right side, fifth intercostal thoracotomy. And what we do, the first thing is basically we divide the inferior pulmonary ligament until we reach to the esophagus, mobilize the esophagus with the surrounding lymph nodes, and basically start delivering the stomach through the hiatus. We fashion the conduit inside the chest and start anastomosing inside the chest. I cannot emphasize more on the fact that your right gastric and right gastroepiploic are the most important vessels in or during stomach mobilization. So what are the possible conduits if you damage your stomach? The other conduits. The other conduits are stomach, besides stomach is colon and jejunum. But the best conduit is the stomach. Why? Is because it requires only a single anastomosis, and generally they have a very good blood supply. Okay. So Ivor-Lewis, we basically went through the steps. Now McEwen. In Ivor-Lewis, we started with the abdomen, but McEwen, which is three-hole techniques, we start in the chest on the right side. So we mobilize the esophagus, the whole esophagus, from the diaphragm up to the neck, and then we close the thorax, reposition the patient, reposition the patient and open up the abdomen and the left neck, and start mobilizing the abdomen, fashioning the conduit inside the abdomen, and then we deliver the stomach through the hiatus and the posterior mediastinum, where the second team or the other surgeon is basically waiting for me, waiting for the stomach and the neck, and then they carry on with the anastomosis in the neck. This is McEwen technique. The other type of esophagectomy is called transhiatal. More or less, the steps are more or less the same, but in transhiatal, we don't open the chest. The chest is not going to be open, and the stomach or the stomach conduit is actually delivered through the hiatus to the neck where the anastomosis occur. So whatever technique nowadays, actually we can do it by minimal invasive, and we all know the advantage of minimal invasive, which is less pain, faster recovery, and shorter hospital stay. At the end of the day, whatever you do, you're going to end up having this picture basically. The picture of the esophagus, the tumor, and the rest of the stomach. Now, what I want you to know here is that, remember I told you last time that the drainage of lymphatics is actually kifled, longitudinal. This is the situation where we use it. So the tumor is here, and the cut end is going to be here. That is more than 10 centimeters. So you have to ensure that the proximal margin is at least 10 centimeter, at least 10 centimeter. Whereas distally, the margins, you want it to be at least 4 to 5 centimeters, okay? So this is what you have to know in this situation. Post-operatively, we usually extubate the patient in the operating room. I send them the first night in the ICU just to resuscitate and hydrate. Next day, if they don't have any problems or complications, then we send them to the ward. I usually start feeding them within the first day, keep them fasting for 6 or 7 days. On day 7, we repeat, or we ask for barium swallow. If they pass the barium swallow, no evidence of leak, then we can start feeding them gradually. The average or approximate hospital stay is between 9 days and 14 days. The possible complication, most common complication post-esophagectomy is actually respiratory, which is in about 15 to 25%. But what we worry about is sepsis and anastomotic leak. The anastomotic leak is more if the anastomosis is actually in the neck, and less if the anastomosis in the chest. But the problem with chest anastomosis, I know it's probably less leak rate, but if they leak, it's going to be really a bad condition. The morbidity will be high, and the hospital stay will be even high. It's really dealing with anastomotic leak in the chest is really hideous, and it requires a lot of work for the patient, from the patient, and from the treating doctors. In order to decrease the complication percentage or rate, I think esophagectomy is better to be done or operated in high volume center, in which there will be a decrease in complication rate and decrease in mortality rate from 18% to less than 5%. The reason for that is not because they have a super duper surgeon, but I think the reason behind that is because it's an approach of team that is trained to deal with esophagectomy and esophageal diseases. So it's a team approach is the key for treating those patients. So what we do in Kuwait, here we receive referral from other doctors. We review all investigation and the pathology. Sometimes we ask for a second look from the pathologist to confirm the disease and make sure that all investigations are aboard. And once we did that, then we usually discuss with the referral doctor and discuss the patients in the tumor board. Sometimes, but not always, we do our own endoscopy before surgery, but always I do it intra-op, basically. So if we decided to go ahead for surgery, our approach for esophageal carcinoma is actually minimal invasive approach. We use a modified McCowan, in which what we do, we start in the chest with uniportal approach. That's probably 1 or 2.5 centimeters incision, and we mobilize the whole esophagus from the hiatus up to the thoracic inlet in the neck, with the surrounding lymph nodes, and sometimes what we do is actually prophylactically we clip the thoracic duct, decreasing the risk of getting chylothorax post esophagectomy. After we finish mobilization of the esophagus, then we reposition the patient supine, and then we approach the abdomen through laparoscopy, starting mobilizing the stomach, preserving the right gastric and gastroepifluic. Sometimes we fashion the conduit inside the abdomen. Other times, actually, I do 4 to 5 centimeter laparotomy, incision mini laparotomy, and fashion the conduit outside extracorporeal. Afterwards, we deliver the conduit through the hiatus into the hiatus to the neck. In the neck, my colleagues, the second team, perform the anastomosis. The anastomosis we use is hybrid procedure. We use a technique called Mark Oringer technique, in which we staple off the posterior wall of the conduit and the esophagus, and the anterior wall actually is closed manually with simple interrupted bicual sutures. That is almost everything about the surgery of esophageal cancer, but I would like to talk a little bit about chemo and radiotherapy. The chemo and radiotherapy preoperatively is very beneficial, but postoperative chemo and radiotherapy is not really, it doesn't have any survival or survival benefits. Pre-op chemo and radiotherapy decreases the bulk of the tumor, increase your curative resection, and of course, delay or eliminate metastasis later on. Whether you do chemo radiotherapy or chemo alone, I think chemo alone preoperatively is still controversial. The North American trials showed no benefits of using chemo alone pre-op, but a British trial, they showed a marginal benefit of chemotherapy alone as neoadjuvant. The cross trial is most of the oncologists they use. It's basically a multi-approach therapy for esophageal cancer, in which we give a neoadjuvant chemoradiotherapy followed by surgery. In the cross trial, it showed a huge benefit in survival compared to surgery alone, and the rate of recurrence again compared to surgery alone. The regimen was basically they give radiation 45 gray and chemotherapy, cisplatin and 5-FU for 45 days or so, followed by surgeries after 4 to 7 weeks from the last day of neoadjuvant. And in subgroups that have complete response, they showed a better survival. Recently, the world basically and the oncologists are shifting their interest into the immunotherapy.
Hello. I think, yeah. So that shown that immunotherapy actually improved the recurrence rate and decreased the locally advanced squamous cell carcinoma that show a genetic mutation as a PDL1, like PDL1. So the last part of this talk is actually the palliation, the palliative care for patients that are not amenable for surgery, like an advanced disease. You can palliate him. The idea of palliation is actually to control the dysphagia and symptomatic relief, and of course to improve the quality of life. Many methods to relieve the dysphagia, especially endoscopic methods, which is applying stent or inserting stent. We can definitely use radiotherapy or chemotherapy, or sometimes use laser like photodynamics therapy. All of those techniques are beneficial and may help the patient and may improve the quality of life. I would like before ending this lecture is actually I would like to show this quick video, like 4 minutes video. How we perform the esophagectomy in McEwen technique. So here we started in the chest by releasing the inferior pulmonary ligament, and then opening up the mediastinal pleura until we reach the azygous vein. Then we dissect or divide the azygous vein, actually at this level where the anastomosis occur in Ivor Lewis. Here what they're doing is actually making sure that we take all the fat pads around the esophagus, which includes the lymph nodes. Then we encircle the lymph nodes, encircle the esophagus, and continue mobilization of the esophagus up to the neck. All right. Here, sometimes what we do is we actually prophylactically clamp the thoracic duct. So still dissecting, mobilizing the esophagus, trying to remove all the lymph nodes surrounding. Okay. Now they identify the thoracic duct, which gonna be clipped prophylactically to decrease the risk of chylothorax post-operative. Then the patient is repositioned for abdominal part, in which we mobilize the stomach carefully, preserving the right gastric and gastroepiploic. Here now we're mobilizing from the colon, the stomach from the colon. A bit of cauterization to ensure good mobilization of the conduit. Right. This is the left gastric. Usually we divide left gastric, and then actually some people or some surgeon, they like to take a wedge from the margin and they send it for histopathology. Here we do pylarotomy, but in recent years I haven't done pylaromyotomy or pylotomy because sometimes I inject Botox into the pylorus. Right. Now the gastric conduit is completed. Now we're attaching the resected stomach with the conduit and then delivering it through the hiatus, as in top corner in the screen. Gently pushing up the stomach into hiatus. The other team is receiving the conduit Then there is a stay suture. We put it between the conduit and the esophagus. And the abdomen, before you close, sometimes we attach the stomach to the hiatus to prevent a hernia, a herniation of the stomach and or herniation of the other abdominal content. That's in the neck. The staple line after resecting the esophagus is long, so most of the time we do an inverting lumbar suturing. Now you've seen that staple is basically going through the posterior wall for both the esophagus and the conduit, and now they are closing the anterior wall with simple sutures, absorbable here. It's continuous, but we use interrupted vicryl. Returning back the anastomosis, and that's about it. Thank you very much for at least staying and listening to this lecture. And if you have any further questions we cannot answer today, then you can contact me with this in this email.